So let's just touch upon a very important topic for part one and part two, especially part two, annual clinical practice, pharmac, lithium toxicity. Now, lithium, the therapeutic range of lithium is very narrow. So it only works well if the dose is between 0.4 to 1 millimoles per liter. Less than zero point 0.4, it will be ineffective, and more than 1, it will probably cause toxicity. It usually is toxic when the dose is more than 1.2 or 1.5 millimoles. Take 1.5 for nice guidelines. Now, there are certain risk factors which will precipitate lithium toxicity. Yeah, so well, one of the things you need to know about lithium is that the peak levels of lithium will be around 2 to 4 hours. And once you've put the patient on lithium, you need to monitor the dose every 3 months, okay, because it will damage the kidney eventually. So, what are the risk factors for lithium toxicity? Anything which will affect the renal elimination of lithium. Anything which will affect the kidney will cause lithium toxicity. Why? Because this almost exclusively is excreted via kidney. So anything affecting the kidney will cause lithium toxicity. So the other causes will be dehydration, very important, renal failure, hyponatremia, NSAIDs, diuretics. Diuretics, especially thiazides. Okay, thiazides will precipitate lithium toxicity. ACE inhibitors, ARBs. Okay. So all these will exacerbate lithium toxicity. Now, if you do an ECG of these patients, there can be prolongation of QT interval to more than 500, and there can be flattening of the T wave or T inversion. Now, you also need to look for other metabolic causes. Sometimes, most of the cases the patient will come in acute lithium toxicity with certain cerebellar signs or some tremors. And this will be secondary to hypovolemia or dehydration, to any GI symptoms like frequent vomiting or diarrhea. So they will have some metabolic tendencies like hypokalemia. There can be AKI, so creatinine will be high, low BP, bradycardia will be there. So check the ECG according to whatever metabolic abnormality you are conjecturing in this patient. Now, the clinical features will depend on the level of toxicity. Suppose if the patient is coming with more than 1.5 millimoles per liter, then the patient might have vomiting, diarrhea, patient will have AKI, weakness, confusion. If the patient is coming with more than 6 millimoles, then here the cerebellar signs will come, like ataxia, dysarthria, fasciculations. Okay, hyperreflexia will be there. There will be tremors here and convergence. Now, usually what we do, we just give them saline and then we monitor after for 24 hours. But as per NICE guideline, we have to be very proactive in checking and treating these patients. So the patient will come with all these clinical features with polyuria and all that will also be there. What you do is first grade it 1, 2, and 3. Grade 3 is comatose. Cerebellar signs will be there because of cerebellar edema. Grade 1 will be when it is 1.5 to 2.5. Also, you need to check the clinical features as well. So, in these patients, what you do, you will hydrate them well. Hydration, 4 to 6 hours. Now, here they've also recommended K exhalate, but this might not be there in your exam because it's an international exam. So, this term might not be familiar to other international students. So hydration is the mainstay in this level of toxicity, 1.5 to 2.5. If it's 2.5 to 3.5, then in this case, again, hydration with K exhalate. This here, according to the clinical feature, you will decide whether you need to hemodialyze the patient or not. Suppose if the patient is having cerebral signs, or you're not expecting that the toxicity will reduce significantly in the next 24 hours, so then go for hemodialysis. Grade 3 will be all cerebellar signs will be there, seizures and coma will come. Here you have to do hemodialysis. Okay? Hemodialysis. In the first hour, also you can do give activated charcoal, but usually the patient will not come within 1 hour. So this is not very acute. It's a bit transient. It will require around 24 to 48 hours. So that's it about lithium toxicity. You have to know that it has got a narrow therapeutic index. You need to monitor the levels every 3 months. Okay, usually the patient will have history of depression or bipolar disorder. They will not directly mention the patient is on lithium, and then this patient will go for a hike and suffer dehydration, or will come with vomiting or diarrhea or some GI loss, or might be put on a newly ACE inhibitor due to hypertension or something. There will be some precipitating cause. There will be some primary disease for which lithium is given, and they will not mention, of course, if the patient is on lithium. So you have to look for all the symptoms and metabolic abnormalities which we discuss, and then you have to treat accordingly. It's very simple, but it needs a high degree of suspicion to get this question right. Okay, thank you so much.